in many patients. I'm still using R-CHOP, but if patients are double, triple hit, then we are using dose-escalated EPOCH. And in patients who are germinal center with advanced disease, I am incorporating polatuzumab in more patients. I interestingly did have a testicular patient who was, really had isolated disease just to the testicle. And so technically early stage, if we want to say that, but it was testicular. And so I used our Pola-CHP in that patient as well. So those are my three buckets. In very early patients, I would also say I still continue to use either 3 cycles of R-CHOP followed by radiation if they aren't in those aforementioned, or I will use 4 cycles of therapy and no radiation if their disease is in a site where radiation would be difficult.
So great answers. So Tara, I'm going to sort of take you to sort of not exactly answer the same way that Suzanne did, but because Suzanne gave us some kind of food for thought in terms of what patients could we use Pola-R-CHP or R-CHP in. And I think that's probably one of the most controversial topics in all of first-line treatment. So how do you decide which patients you will give polatuzumab to, Tara?
That's a great question. And actually, I was just thinking about that when you were kind of going over the pathway. For the longest time, nothing rivaled R-CHOP, right? We didn't have anything that could really even hold a candle to it. And so for the longest time, it was either R-CHOP or dose-adjusted R-EPOCH for those higher grade patients and the obviously double hit, triple hit. And then lo and behold, we have Pola-R-CHP that comes, sort of, into the ring with R-CHOP. So the way that I make a decision is if it's a standard, patient, not high grade, not double hit, triple hit, a GCB, not an ABC subtype, I will, often still use R-CHOP. I mean, R-CHOP is still a great regimen. No one's saying it needs to be replaced. But for those patients with an ABC subtype or a higher IPI, I have exclusively started using Pola-R-CHP. Now, for a double hit, triple hit, this is where I think there's still a gray area. I'm not quite ready to give up the dose-adjusted R-EPOCH if there's a 52-year-old with a true double hit or triple hit, large cell lymphoma. I'm still going to want to go for that dose-adjusted R-EPOCH. And again, we're not talking about clinical trial options here. We're talking just standard of care. I would probably still go with that dose-adjusted R-EPOCH. So that's why I was kind of looking at that next question of, what are the largest unmet needs? I think our largest unmet needs, just jumping to that next bullet, are the ABC subtype, the advanced IPI, and those true double hit, triple hit patients. I think we really still need to focus some attention on those core groups because I think the argument still exists between R-CHOP, Pola-R-CHP, dose-adjusted R-EPOCH. And I think depending on where you are in the country and where you trained and who you trained with, you're going to make that decision differently.
So how you are making the decision as to who is GCB and who is ABC? Because that's also one of the controversies, right? In terms of, are you using enhanced criteria and how reliable is that? And if you want to use genomic testing, how accessible and available is that to you in your community? So how are you guys deciding who is GCB and who is ABC and making this decision?
We're able to do we're able to do Path's able to get the information for us where we are. Our Path lab is pretty sharp, so we're able to do it. I will still do the Hans logarithm myself while I'm waiting sometimes. But I like that confirmatory test. Obviously, when you're doing a trial, it's a little bit different. It's sort of it's confirmed for you at an outside lab, but we're able to get that where we're at. But you're right, it's not always available. So if you're just doing yourself based on markers, is it really accurate? We don't always know. And we know that there's times in which we think it's going to be, a germinal center and it's actually an ABC or vice versa. So it's not a perfect science.
Suzanne, how you are doing it in South Carolina?
Yeah, so I mean, I agree with Tara that our path lab identifies it based on flow. It's the double hit, triple hit that are coming from the fish results. But I'm unlike Tara that I'm not necessarily doing it ahead of time. I'm waiting. But thankfully, I don't have to usually wait too long. And I did say our chip. I said our chop instead of our chip. So Tara, I was listening to you say that.
Oh,
And so yeah, you corrected me. But yeah, Path Lab is getting it done for us, and so I don't have to think too hard about it.
Okay, so sort of taking you, both of you mentioned dose-adjusted epoch, which is also controversial in itself. So what do you all think about, the SWOG data, and where does, dose-adjusted R-EPOCH truly fit in the treatment of patients? Is that still a regimen that we should be using, or you think there's enough data that we can use it for those very high-risk patients?
I also think that you have to take into account the patient in front of you. And so I hear what you're saying because the vast majority of these patients are older and they're not all dose-adjusted R-EPOCH eligible patients. But for those patients who are appropriate for a more difficult regimen, I would go with that regimen if they are able. I mean, we all have patients who sometimes are getting mini R-CHOP because that's the best that they can receive. So I think it depends.